Good afternoon, everybody, and welcome for today's presentation. Uh, we will start first with the objectives that we hope to achieve by the end of today's session. So, we would take a look into what are the salient characteristics of families of adolescents. What does family therapy do, and why family therapy for this particular population? What are the important issues to note while working with the families of adolescents? And is there an evidence base for family therapy in adolescent psychiatric disorders? So this is what we hope to achieve uh, in today's presentation. Yeah. Before we go ahead, let's see what are the possible scenarios where family therapy can be considered. So, in a way, when to consider family therapy. Uh, so, it can be considered when there is a presence of psychiatric disorder in any of the family members, but today we'll be sticking to adolescent being the index patient. So, any diagnosis of psychiatric disorder in index patient. Then active family discord, which can be very often identified by the family members themselves, where they seek help for that. So that may be one scenario. Then there could be violence in the family, which again indicates need for family intervention. This violence could be from the part of the adolescent towards the parents, and if it's from the other side, then that has to be considered as abuse, which could be of physical nature, sexual, or emotional. Uh, Family therapy can also be considered when we have suicidal adolescents, if there is incest in the family, any family members having diagnosis of personality disorders, and even certain, what we call as special conditions where there are single parent families, if the adolescent is adopted, and if there are any physical or mental disabilities within the family. Now, before we go further, I purposely put this slide first because I think it is important for us to see the scope of today's presentation and also to see, understand that what is it that we will not be touching up today. So, as you can see, some of these conditions are listed here. They are relatively rare. For example, the single parent families, adoption, and adolescents with disabilities. Now, apart from the routine family therapy that we do, to handle these conditions, there may be certain additional extra skills and training that may be required for the family therapist. So, today's presentation will not be enough to be able to give you guidelines to handle these scenarios. And another thing that I would like to mention is, in case of severe psychotic mental illnesses, the approach that we adopt for family therapy is entirely different, and there's going to be next presentation fully devoted for that topic. So again, those categories are excluded from today's presentation. So then you may want to ask, then what is it that we can keep in mind while looking at today's presentation. So our common mental disorders, for example, internalizing spectrum, externalizing spectrum, that you can keep in mind. We will start with the case vignette, which will give you an idea of what is the typical scenario that we get to see very often. So let's start with the vignette. Yeah, so this is a case. This is based on a real case that I've seen in our family psychiatry center. It's a 16-year-old girl presented with complaints of refusal to continue studies, deviant peer association, history of breaking rules at school, experimentation with alcohol and hookah, and frequent fights with the mother over demanding behaviors. The father of the girl is a 43-year-old senior IT professional, and mother is a homemaker who is 40 years old. Now, the index patient is the only child of her parents, and in this family, father has been staying away from the family due to his job in another city, and the duration was that for 4 years. There were disagreements between parents on multiple issues regarding parenting, lifestyle, and career. So this is a very typical case that I thought would be representative to have discussion in today's topic. We will keep coming back to this, so keep this in mind. We will make links in our further presentation to this case. Okay, before we go ahead, one more thing I would like to I would like to make is that, as all of you are aware from previous presentations also, that there are multiple schools within the area of family therapy. Like, for example, psychodynamic, structural, strategic. Now, it is a little beyond the scope of today's presentation to touch upon all these. However, there is a common link between all these schools, that even when they have different unique ways to understand health and illness in family, and different techniques employed on the basis of that understanding, the common link that is present throughout these schools is that all of them follow systemic orientation. So by systemic orientation, we mean that their understanding of the entire family unit is that it is a system with interconnected parts which are interdependent on each other, and the understanding of causality is circular, it's not linear. So basically, that systemic orientation is what I'll be focusing in today's presentation. So I request all of you to keep that in mind. We may not be able to give you many detailed inputs from particular school. Even in our therapy at the center, we often use integrative approaches where the decision of the techniques that we employ is based on the mostly the clinical need of the case and the family. So having said that, now we go ahead. So before we understand that the needs of this population that we work with, I think it will be interesting to take a peek into adolescents' life. From a developmental perspective, we know that at every stage of development there are certain tasks to be achieved which are very imperative for the psychological health for a person. So when an individual enters adolescence, there are certain typical characteristics or the developmental tasks that they have to achieve. So one of them that we know that there is this active search for identity, and it's a period to form one's identity, which may be in terms of sexual identity, where one has to deal with the rapid bodily changes, has to become aware of one's own sexuality, other sexuality, and handling sexual impulses and ways to deal with it. Then we come to gender identity. This is another dimension of identity where adolescents will actively have to sort of align their behaviors according to the gender role expectations and sort of take decisions about that. Then there is a moral and spiritual dimension to the identity as well, where, as all of us know, that cognitively this is a time where they develop ability for abstract thinking. So there's an active search for choosing one's values and forming a belief system, which sort of can become a philosophy of life and can guide them further. So this is a time overall for identity formation. The second aspect, or the second developmental task that adolescents have to face is that they need to develop social competence, which may involve basically understanding one's relation of oneself to peers, to family, and then community at large. This is also a time where it's characteristically they're emotionally very unstable. So very typically an adolescent may be over functioning at one point in time, and they may be under functioning at another point in time. So striking a balance and achieving relatively relative emotional stability is another crucial task of this stage. They also learn to work independently, to rely on themselves, and also to be good team members, to work collaboratively, which again requires a lot of social skills, social cognition. Also, there has to be an ability that develops which helps them to judge and handle complex social situations. So all this together basically calls to develop social competence on adolescents' part. I think adolescent narcissism is something that all of us, whoever have interacted with adolescents, is very well aware of. They're more interested in the outside world. They're more and more interested in bringing new ideas into their lives, into the family's lives. So they want to explore the world. And there is, so overall there is this focus on one's own self, where there's almost a sense of being the center of family's attention, or maybe the center of the world. As a result of this, they, in this process of exploration, very often they question the established stereotypes. They may come across as rebels, and may question prejudices, may question stereotypes. So there's this overall dimension of narcissism that is very evident when we interact with any adolescent. Lastly, there is a essential developmental milestone of achieving this separation individuation, and the process is something which starts here at the time of adolescence. Now this process involves transcending the internal representations of parental models and renegotiating a separate sense of self, which means that there is a decrease in the psychological dependence that one has on parents in terms of having a sense of self-esteem, in terms of setting standards for behavior. So this is a stage where they will sort of try to go beyond the parental ideas of that, and then they will want to explore their own separate sense of self. Now this process calls for a balance between the autonomy and connection, where they on one hand try to achieve a separate sense of self, but at the same time they retain meaningful connection with the parental representations as well. So this is a crucial process that all adolescents go through. Even in there could be cultural differences in this process, but studies in India have shown us that even in a collectivistic culture like Indian, our adolescents do go through this process, and they are able to achieve, and they are able to reach separation from their parents. However, the studies have been in the community population. In clinical scenarios, you may feel that many adolescents struggle at this stage, and specifically at this stage is where the entire family has chances of getting stuck. So now we move on to take a peek into families of adolescents. So as we know that each individual moves from one life cycle stage into the other, similarly, we have understanding of families transitioning from one developmental stage to the another, where together as a family they have certain developmental tasks to achieve, again, which successful achievement of them can contribute to their health, otherwise illness follows. So let's see what are these tasks of families of adolescents. So one point here to remember is that individual life cycle tasks that we talked about for adolescent, they are embedded in the larger family life cycle stage. So they are connected. So they unfold in the context of family, which poses a lot of challenges to the entire system. So the separation individuation can be a potential threat to the family stability, because as I said, they will move on from the parental ideas of standards of behavior and ways of leading life, and then there will be a lot of questioning that may be happening on their part. So that will call for a lot of reorganizations in the family structure. So this is a period which is likely to test the flexibility of the family organization as well. So there is definitely a need for a renegotiation of family structure and boundaries. For example, it is no longer constructive or helpful for the family to maintain the earlier hierarchical systems which may be there in the earlier life cycle stages, where the children are school going, where they are easily accepting or willing to accept parental authorities. Here that won't be possible. So a family will have to sort of make the rearrangements in the structure in order to help adolescent move in and out of the system. So this is a task for the family. Then apart from that, they also have to respond to needs of the other family members who may be in different life cycle stages. For example, there may be younger children in the family who are school going. So they have to cater to their need, or there may be grandparents in the family who are in the later stages of life cycle. So family will have to sort of look into the needs and take care of needs of all these family members. When children enter adolescent, very typically their parents midlife overlaps with that phase. So this is a phase where parents may or may not experience midlife crisis in terms of their marital relationship, in terms of their career. So there is a tendency to sort of take a review, and as a result of that, even many parents may be susceptible to develop certain psychiatric conditions. So and this is a very normative thing. Parents also have to care for older generations, which may be there simultaneously in the family. So overall, now you have understood that it's not just the adolescents who enters this particular life cycle stage. It's the entire family system which undergoes a lot of changes. So it's a system in flux. So now, having understood this, it's very logical that what is it that we do in family therapy has very close connection to ensuring families' health through this transition. So very often you will see that whatever we spoke of is a very normative process. Every family goes through that. However, our clinical families or families where there is dysfunction, you will see that they either get stuck at the earlier developmental stages, or they may not have enough resources to make this transition successfully. So family therapy basically helps these dysfunctional families to have this transition relatively smoothly. Now, for example, let's go back to the case vignette that we had. You could see from the information that the family was not staying together in the first place. So the challenge of the family was to, in the first place, come together and form a unit. So there were a lot of, in this particular case, there were a lot of issues from the earlier life cycle stages that family had not achieved. So the family required help from that perspective. Then another goal of family therapy is to enhance the process of identity formation in the adolescent. So this basically implies that adolescents are, as I said, they try to explore, they try to experiment with their values, with different ways of behaving. Now, within the family, there has to be a room and space for that. So that's going to be one of the goals of family therapy, to create that room, for which we need negotiations between the parent-child relationship, which they may not be used to, especially in case of our Indian families, where parents tend to take more authoritative stance, and children may be used to, or even the parents may be used to that in earlier life cycle stages, that they take the word of authority. However, that may not be possible, or that may not be helpful, so to say, in this particular life cycle stage. So family therapy sort of has to teach these negotiation skills for both the parents and the adolescent, which calls for a skill to be able to have a dialogue and not just to have a monologue. Many times parents they feel that they have interacted or they have had a conversation with their children, but if you closely have a look, it's a one-way sort of a lecture or a monologue. So one of the goals of family therapy is to facilitate this dialogue between them. Then another goal is to interrupt the dysfunctional alliances and coalitions in the family. Again, I would like to go back to our case vignette to explain this point. As a result of this particular patient having stayed more with the mother and away from the father, very naturally, her relationship with the mother was very enmeshed. So mother would be there present, in every small aspect, and even offering help before she needs it. So this is sort of a dysfunctional alliance that we call in the context of family, where that is not helping our index patient to take responsibility for herself and become more autonomous in her functioning. So this is definitely an alliance that we would want to interrupt in this particular family and bring about a balance. So in family therapy, after interrupting these dysfunctional patterns, we would aim to help the family develop new adaptive interaction patterns. Uh, we also help them maintain meaningful contact with the adolescent and also focus on other relationships in the family which may need help. It happens very often that, especially when there is a psychiatric condition in the index patient, that all the focus of the family is on this patient, and then the other relationships in the family often get neglected, including the marital relationship. So it is a very common experience of ours where, when parents come for family therapy, uh, they many times realize that we have been so engrossed in our roles as parents that we have forgotten that we are husband and wives also, and we have these commitments to each other. So this again happens very often in clinical families. So we help them to sort of balance their energies into the multiple roles that they have to play. In terms of parenting, we also need to help them balance their nurturing and authority functions. Very often, there is a confusion between the understanding of obedience and understanding of, sense of responsibility. So this is something that we need to sort of differentiate and help them with. Even the nurturing function, I think it's important that we assess these behaviors right in the beginning, because very often parents confuse their worrying for their children as their nurturing function, which is not so. So that is something that will help to keep in mind. Lastly, there may be unresolved issues in the marital relationship of parents, or issues that they have with their families of origin, now which may surface up in the process of family therapy. Like, for example, in this case that we have been talking about of a 16-year-old girl, initially when they came for therapy, it was at the extent of disagreements between the parents. However, as we proceeded further in therapy, more serious family marital discord surfaced up, where we understood that the marriage was not functioning well in terms of their needs for emotional intimacy and physical intimacy. So that element lacking from the marital relationship, that had direct bearing upon the functioning of the family. So this is something that we need to keep in mind, that treating marital discord would be one of the major goals of the family therapy. And even in terms of outcome, we will speak about that very soon. This has a direct bearing for the outcome of the success of family therapy as well. Another point to note at this stage is, very often parents come for therapy because there is a problem in their adolescent. However, there may be issues, there may be psychiatric conditions, or even certain personality traits that may be present in parents, which may not get attention of the teams in the beginning. So we have to keep that also in mind, which may require extra help for the parents. Okay, so there are some points that now I would like to make, which we can keep in mind while working with this population. In the phase of assessments, we need to sort of, there are certain typical patterns, dysfunctional patterns that may surface up. So in this particular population, so it's good to have understanding of them. One typical pattern is that families with dysfunction, they bypass confrontations and then they avoid conflict. They refuse to acknowledge conflict. So conflict avoidance we need to look for if that is present. There could be diffusion of conflict where they jump from one conflict to the other without resolving any one of them. There could be enmeshed relationships, again very typically present in Indian families, where they're all the time with each other, and then there's hardly any space for a person to function independently. They may be mutually influencing complementary behaviors. For example, in context of families, the behaviors fit together very well. They're mutually reinforcing. So, for example, we need to ask this question that if there is a dysfunctional behavior, or there's a symptomatic behavior that the adolescent is exhibiting, what in the family is encouraging, or what in the family is contributing to maintain that? So that's one aspect. Rigidity is another pattern that we need to carefully look for. This is particularly present in families where there are suicidal adolescents. Now, the concept of homeostatic maintainer is very central to family therapy, where we look at what are the forces that are working in the family which sort of prevent it from bringing about changes that are required at this phase. So homeostatic maintenance is the tendencies of the families to maintain their status quo. So there could be, either a one family member who contributes to this and prevents changes from happening. So that is something that we need to identify. There could be intergenerational transmission of pathology. There could be patterns that you would see in the genogram analysis which get transmitted from one generation to the other generation. So looking for that will also help. So what do we do actually in therapy? In therapy, family therapist plays a very active role, requires a lot of skills, because most of the times we prefer conjoined sessions where we see both the parents and the adolescent together. At times we do take separate sessions, but only if it is required. So there are conjoined sessions, and therapeutic alliance with the adolescent and family members is very crucial for the outcome. The alliance with each member of the family is required while maintaining neutrality. And I think this is very crucial, because if there is no neutrality, and if one of them feel that you're taking sides with the other person or with the other subsystem, you are likely to lose your clients, or there may be high dropout. So this is a very crucial aspect. The goals for therapy have to be formulated in a collaborative fashion, where there has to be active involvement from the part of the adolescent. Otherwise, the cooperation that you will receive in therapy will not be good enough. So one of the important goals that we keep for family therapy is to reduce negativity that exists in the family, because it interferes in the process of communication and effective problem solving. There are certain techniques which process research in family therapy has found to be very useful for this purpose. One of them being reframing, where we sort of activate the other parallel realities for them to see and have a different understanding of the symptomatic behavior in a newer light. So we provide sort of a positive explanation for the symptomatic behavior. So if the daughter says that my mother is, she never trusts me whenever I go out, in this case, the case we need, my mother never trusts me. So this could be reframed as mother's concern for her safety and not the mistrust that she shows. There could be exceptional questions that we can ask, because very often there are patterns that keep getting repeated. So, they feel that, that it's only the negativity that's present. So to dissociate from that, to distance from that, they could be, asked about the times where the problem behavior does not occur and how they're different from the times when it does occur. So exploring that will be a good idea. We also actively look for competence in family members. We go with the understanding of multifaceted self, where we try to look for the functional aspects. Crucial subsystem that is always the focus of family intervention is the parent-child interactions. So we need to see if any one of these issues are present which need attention, in terms of lack of warmth, poor communication, lack of support, emotional distance, and rejection. As I had already mentioned, that there would be a tendency for families to maintain their status quo. So it is very common to encounter resistance in the process of family therapy, for which being more facilitative and collaborative will help, rather than adopting teaching or confrontative interventions.